Introduction. A patient who is having difficulty breathing requires immediate care. Respiratory distress can quickly progress to respiratory failure, respiratory arrest, and cardiac arrest. Pathophysiologic mechanisms contributing to respiratory emergencies. Respiratory emergencies arise due to problems with ventilation, diffusion, gas exchange, or perfusion. Problems with these processes may have many different sources. Inadequate ventilation. Problems with ventilation occur in the presence of conditions that affect the body's ability to move air in and out of the lungs. Conditions that can lead to impaired ventilation include airway obstruction, neuromuscular conditions, central nervous system conditions, chronic lung disease, and trauma. Inadequate diffusion and perfusion. When diffusion is impaired, the exchange of oxygen and carbon dioxide between the alveoli and the pulmonary capillaries is affected. Respiratory distress represents the earliest stage on the continuum. A patient in respiratory distress is using compensatory mechanisms to maintain adequate oxygenation and ventilation. The patient's work of breathing is increased, but physiologically, oxygenation and ventilation are adequate to meet metabolic demands. However, if the patient's respiratory distress is not relieved, these compensatory mechanisms will soon become inadequate, at which point the patient may develop respiratory failure. Signs and symptoms of respiratory distress may include dyspnea, use of accessory muscles to assist in breathing, evidenced by supraclavicular, suprasternal, intercostal, or substernal retractions, diaphoresis, irritability, restlessness or anxiety, changes in level of consciousness, cyanosis, decreased, absent, or abnormal breath sounds. For example, wheezes, crackles, rhonchi, speech dyspnea, changes in breathing rate or depth, tachycardia or bradycardia, decreasing O2 saturation levels, and end-tidal carbon dioxide levels that are initially low, less than 35 mmHg, but with increasing distress move into the normal range, 35 to 45 mmHg, and then become elevated, greater than 45 mmHg. Respiratory failure occurs when the respiratory system can no longer meet metabolic demands. Respiratory failure usually represents a progression from respiratory distress, but patients may also initially present in respiratory failure. Respiratory failure must be addressed quickly to prevent respiratory arrest. Signs of respiratory failure could include changes in the level of consciousness, cyanosis, O2 saturation values less than 90%, end-tidal CO2 values greater than 50 mmHg, tachycardia, and a decreased or irregular respiratory rate. Respiratory arrest is complete cessation of the breathing effort. The body can tolerate respiratory arrest for only a very short time before the heart stops functioning as well, leading to cardiac arrest. Patient assessment. Data gathered during the rapid, primary, and secondary assessments can help you to determine where the patient is on the continuum of respiratory compromise and may offer clues as to the underlying cause. Signs of respiratory compromise that you may observe during the rapid assessment include retractions and the use of accessory muscles to breathe, tripod positioning, an inability to speak in complete sentences, or at all, pale, ashen, or cyanotic skin, diaphoresis, and restlessness, agitation, or an altered level of consciousness. Conduct a primary assessment following the ABCDE approach and provide initial interventions as needed. Ensure a patent airway, assist with ventilation as necessary, which is initially provided using a bag valve mask resuscitator. Establish pulse oximetry, and provide the minimal level of supplemental oxygen needed to maintain an oxygen saturation of 94% to 99%. Establish capnography and adjust ventilations as needed to maintain carbon dioxide levels in physiologic range between 35 and 45 mmHg or monitored using end-tidal CO2 unless another target is clinically indicated, and establish vascular access. The secondary assessment will often help to further discern the underlying cause of the respiratory compromise and evaluate the severity of the patient's condition. For a patient with respiratory compromise, interventions depend on the underlying cause. Common interventions include supplemental oxygen, medications specific to the underlying cause, and assisted ventilation, non-invasive ventilation, or invasive ventilation. After any intervention, reassess the patient to determine response and adjust the treatment plan as necessary. Monitor the patient for signs of worsening respiratory function, such as increased work of breathing, an increase or decrease in respiratory rate, hypoxemia, or mental status changes. Use the pulse oximetry and capnography for continuous monitoring. If the patient in respiratory arrest is not breathing but has a pulse, ensure a patent airway and deliver one ventilation every 6 seconds. Provide ventilations by BVM initially. Provide mechanical ventilation as indicated. Provide high-flow supplemental oxygen, titrating to achieve and maintain an oxygen saturation of 94% to 99%. While supporting ventilation, consider and address potential underlying causes. Perform a primary assessment and provide emergent initial interventions if not already done. Continue to check breathing and pulse every 2 minutes. If the pulse becomes absent, begin CPR immediately. Position the patient as appropriate for their clinical condition and perform a secondary assessment as the patient's condition allows. The data you gather through ongoing assessment of the patient informs the decisions that you make in order to provide appropriate care. Taking a systematic approach to assessment allows you and the team to focus on identifying and addressing the most critical problems first, and helps to ensure that important details about the patient's condition and underlying causes are not overlooked. A systematic approach to assessment includes a rapid assessment, a primary assessment, and a secondary assessment. The rapid assessment is a quick survey to ensure safety. Form an initial impression about the patient's condition, including looking for life-threatening bleeding, and determine the need for additional resources. You can gain a great deal of preliminary information very quickly just by looking at the patient. For example, does the patient appear to be unresponsive? Is the patient speaking? Does the patient appear to be working to breathe? Does the patient's skin appear to be its normal color? Or does it seem pale, ashen, cyanotic, or flushed? Does the patient appear to be diaphoretic? Is there any fluid or blood coming from, on, or near the patient? Is there life-threatening bleeding? If the patient is responsive, perform the primary assessment and provide emergent and initial interventions. Position the patient as appropriate for their clinical condition and perform the secondary assessment as the patient's condition allows. Continually reassess the patient, recognize issues, and provide care as needed. If the patient is unresponsive, call for additional resources, the rapid response or resuscitation team, and the resuscitation equipment or cart. Simultaneously check for breathing and a central pulse for no more than 10 seconds. While completing the breathing and pulse check, look a second time for life-threatening bleeding. Quickly scan down the patient's body, looking for blood or other signs of life-threatening bleeding that you might not have seen initially. If the patient is able to speak to you in a normal voice, then the airway is patent. If the patient's airway is not open and clear, airway must be restored immediately and maintained. Methods of ensuring and maintaining a patent airway include patient positioning, manual maneuvers, such as the head tilt and chin lift technique, and the jaw thrust maneuver. Techniques for clearing an airway obstruction. For example, abdominal thrusts or foreign body removal using forceps with direct laryngoscopy. Suctioning. Placement of an oropharyngeal airway or nasopharyngeal airway. Placement of an advanced airway. Assess breathing rate, depth, and rhythm and observe for chest rise. Auscultate for the presence or absence of breath sounds. The presence of abnormal breath sounds. For example, wheezes, rales, rhonchi, or stridor. And for bilateral equality. Establish pulse oximetry to monitor oxygen saturation and, if necessary, provide the minimal level of supplemental oxygen needed to maintain an oxygen saturation of at least 94%, but not more than 99%. Establish capnography to monitor the adequacy of ventilation. In tidal carbon dioxide, EDCO2, values in the range of 35 to 45 mmHg confirm adequacy of ventilation. If necessary, support ventilation with bag mask-assisted ventilation, non-invasive ventilation, or invasive ventilation. Assess the pulse rate, quality, and rhythm, and establish cardiac monitoring. Assess the adequacy of perfusion by assessing blood pressure and capillary refill time, assessing for signs of shock and noting skin color, appearance, and temperature. Signs of compromised perfusion include a prolonged capillary refill time, greater than 2 seconds, cool, pale, or cyanotic skin in the extremities, an altered level of consciousness, and abnormally low ECO2 readings, less than 30 mmHg. If time and resources permit, obtain a 12-lead ECG. Determine whether the patient needs defibrillation, cardioversion, or pacing. Establish vascular access for the administration of fluids, medications, or both. Perform quick assessments to gain information about the patient's neurologic status. Assess the patient's level of consciousness using the VPU mnemonic: alert, verbal responsive, pain responsive, unresponsive. Assess orientation to person, place, and time. Check the pupils for size, equality, and reactivity to light. Measure the patient's blood glucose level. Hypoglycemia can cause changes in level of consciousness and is easily corrected. If stroke is suspected, conduct a neurologic examination using the National Institutes of Health Stroke Scale, NIS, or similar assessment tool. As the last step of the primary assessment, check the patient's body for obvious signs of injury or illness, such as bleeding, bruises, rashes, and deformities. Note skin color, appearance, and temperature. Remove clothing as needed to inspect the head, ears, face, and neck, the anterior and posterior trunk, and the upper and lower extremities. If the patient has a suspected head, neck, spinal, or pelvic injury, remember to consider spinal motion restriction while turning the patient over. When the patient's condition has been stabilized, perform a secondary assessment. The secondary assessment includes a focused history, a focused physical examination, neurological assessment, and diagnostic tests. The goal of the secondary assessment is to gather more detailed information that will allow you to narrow the list of differential diagnoses and discover underlying treatable causes. Focused history. The focused history can be obtained by collecting data following the sample mnemonic. S. Signs and symptoms. A. Allergies. M. Medications. P. Past medical history. L. Last intake and output. E. Events. The information gathered from the rapid and primary assessments, as well as the focused history, will assist you in determining the primary area of concern and the extent of the focused physical assessment. For example, if the primary area of concern is respiratory, then the areas of focus may include the head, neck, and chest. In addition to completing a focused physical exam, a complete head-to-toe assessment should also be performed. The reassessment of patient is very important in a secondary assessment to evaluate patient response to the initial and primary management. Diagnostic tests may be ordered to assist in identifying underlying causes, including potentially reversible causes, narrow the list of differential diagnoses, aid in determining candidacy for or contraindications to planned therapeutic interventions. For examples, blood tests, imaging studies, and electrocardiography. Bradyarrhythmias are heart rhythms with a rate of less than 50 beats per minute, commonly due to conduction abnormalities in the heart such as sinus node disease or atrioventricular block. The risk of sudden cardiac death is elevated due to the slowing or stopping of the heart. Additionally, there is an increased risk of falls, particularly among older adults, due to fainting. Patients may present with lethargy, shortness of breath, chest pain, dizziness, and fainting as a consequence of the reduction in cardiac output, and cardiac and cerebral hypoperfusion. Symptoms such as syncope are episodic and often infrequent. Approximately 20 to 40% of patients report an episode of syncope with bradycardia, and this may recur in 10 to 15% of patients. Bradyarrhythmias described in this chapter include sinus bradycardia, first-degree AV block, second-degree AV block, types 1 and 2, and third-degree, complete AV block.
Sinus bradycardia is identical to normal sinus rhythm, except the rate is less than 50 beats per minute. Cardiac activation starts at the SA node but is slower than normal. Sinus bradycardia may be a normal finding in some patients, particularly healthy young adults and trained athletes. In other patients, however, sinus bradycardia is a pathologic finding.
Signs and symptoms. Sinus bradycardia may not cause signs or symptoms. However, when sinus bradycardia significantly affects cardiac output, signs and symptoms may include dizziness or lightheadedness, syncope, fatigue, shortness of breath, confusion or memory problems. On electrocardiogram, sinus bradycardia appears the same as sinus rhythm, except the heart rate is less than 50 beats per minute. AV block is a partial or complete interruption of impulse transmission from the atria to the ventricles. The block may occur at the AV node, the bundle of His, the bundle branches, or the Purkinje fibers. Common causes of AV block include fibrosis and scarring of the conduction system and myocardial infarction. Other causes include medications, such as beta blockers, calcium channel blockers, datixin and amiodarone, electrolyte abnormalities, myocardial ischemia, infectious or inflammatory disorders, and congenital heart conditions. Depending on the cause, AV block can be transient or persistent. AV blocks are classified as first, second, or third degree. First-degree AV block is characterized by a prolonged delay in conduction at the AV node or bundle of His. The impulse is conducted normally from the sinus node through the atria, but upon reaching the AV node, it is delayed for longer than the usual 200 milliseconds, 0.2 seconds. In first-degree AV block, although the impulses are delayed, each atrial impulse is eventually conducted through the AV node to cause ventricular depolarization. Causes. First-degree AV block may be a normal finding in athletes and young patients with high vagal tone. It can also be an early sign of degenerative disease of the conduction system or a transient manifestation of myocarditis or drug toxicity. Signs and symptoms. First-degree AV block rarely produces symptoms. ECG findings. First-degree AV block is characterized by normal P waves that are each followed by QRS complexes. But because the impulse is delayed at the AV node or bundle of His, the PR interval is longer than normal. It exceeds 0.2 second. QRS complexes of normal duration suggest that the delay is occurring at the level of the AV node, whereas wide QRS complexes suggest that the delay is infranodal, distal to the node. In second-degree AV block type 1, also called Mobitz type 1 or Winkelbach's block, impulses are delayed and some are not conducted through to the ventricles. After 3 or 4 successive impulse delays, the next impulse is blocked. After the blocked impulse, the AV node resets, and the pattern repeats. Second-degree AV block type 1 usually occurs at the AV node, but may be infranodal. Because the block usually occurs above the bundle of His, conditions or medications that affect the AV node, such as myocarditis, electrolyte abnormalities, inferior wall myocardial infarction, or medications, such as digoxin, can cause second-degree AV block type 1. This type of arrhythmia can also be physiologic. Second-degree AV block type 1 rarely produces symptoms. Some patients may have signs and symptoms similar to sinus bradycardia. Because some impulses are not conducted through to the ventricles, the ratio of P waves to QRS complexes is greater than 1:1. Because each impulse is delayed a little more than the last until eventually one impulse is completely blocked, the ECG shows progressive lengthening of the PR interval with each beat, then a P wave that is not followed by a QRS complex, a dropped beat. In most cases, the RR interval decreases before each dropped beat. After the dropped beat, impulse conduction through the AV node resumes and the sequence repeats. In second-degree AV block type 2, Mobitz type 2, the block occurs below the AV node in the bundle of His. As with second-degree AV block type 1, some atrial impulses are conducted through to the ventricles, and others are not. However, there are no progressive delays. The blocked impulses may be chaotic or occur in a pattern, for example, 2 to 1, 3 to 1, or 4 to 1. In high-grade second-degree AV block type 2, the ratio is greater than 2 to 1, for example, 3 to 1, 4 to 1, or variable. Second-degree AV block type 2 is always pathologic. It is usually caused by fibrotic disease of the conduction system or anterior wall myocardial infarction. Signs and symptoms. Patients may present with lightheadedness or syncope, or they may be asymptomatic. The clinical presentation varies, depending on the ratio of conducted to blocked impulses. ECG findings. Second-degree AV block type 2 is characterized by a constant PR interval. Because impulses are intermittently blocked, there are more P waves than QRS complexes. In third degree, complete AV block, no impulses are conducted to the ventricles. The block can occur at the level of the AV node, but is usually infranodal. Pacemaker cells in the AV junction, bundle of His, or the ventricles stimulate the ventricles to contract, usually at a rate of 30 to 45 beats per minute. This means that the atria and ventricles are being driven by independent pacemakers and are contracting at their own intrinsic rates, a situation known as atrioventricular dissociation. Causes. Degenerative disease of the conduction system is the leading cause of third-degree AV block. This arrhythmia may also result from damage caused by myocardial infarction, Lyme disease, or antiarrhythmic medications. Signs and symptoms. If ventricular contraction is stimulated by pacemaker cells above the bifurcation of the bundle of His, the ventricular rate is relatively fast, 40 to 60 beats per minute, and reliable, and symptoms may be mild, such as fatigue, orthostatic hypotension, and effort intolerance. However, if ventricular contraction is stimulated by pacemaker cells in the ventricles, the ventricular rate will be slower, 20 to 40 beats per minute, and less reliable, and symptoms of decreased cardiac output may be more severe. ECG findings. In third-degree AV block, there is no electrical communication between the atria and ventricles, so there is no relationship between P waves and QRS complexes. The RR interval is usually constant. The PP interval is constant or slightly irregular. If pacemaker cells in the AV junction stimulate ventricular contraction, the QRS complexes will be narrow, less than 0.12 second in duration. Impulses that originate in the ventricles produce wide QRS complexes. The patient's appearance on rapid assessment can vary widely, depending on the arrhythmia. The patient may appear to be in minimal distress, show signs of hemodynamic compromise, for example, pale, mottled, or cyanotic skin, or show signs related to the underlying cause of the arrhythmia. For example, pain, diaphoresis. Primary assessment. Conduct a primary assessment following the ABCDE approach and provide care as needed. Obtain and monitor the patient's vital signs. Establish cardiac monitoring, pulse oximetry, and vascular access, and be prepared to provide CPR and defibrillation if the patient's condition deteriorates. Provide the minimal level of supplemental oxygen needed to maintain an oxygen saturation of at least 94% to 99%, and provide assistance with ventilation if needed. Assess level of consciousness in patients who appear to have changes in mental status. Obtain a 12-lead ECG if time and resources permit. Secondary assessment. The goals of the secondary assessment are to identify signs and symptoms and determine whether they are being caused by the arrhythmia or another condition. Further determine the severity of the signs and symptoms. Identify the arrhythmia, if not done as part of the primary assessment. Identify potentially reversible causes of the arrhythmia. Key information to elicit during the history includes a description of the patient's symptoms, including a full description of symptoms such as chest pain or syncope, a medical history of arrhythmias, cardiac disorders, or cardiac surgery, the presence of comorbid conditions, including cardiovascular disease, pulmonary disease, and thyroid disease, current medications, including antiarrhythmic agents, physical examination, obtain and monitor the patient's vital signs, and perform a physical examination, diagnostic tests. A 12-lead ECG aids in further identifying the arrhythmia. Additionally, a complete blood count, comprehensive metabolic panel, arterial blood gases, and cardiac markers may be considered. When bradyarrhythmia is suspected, the team takes actions to ensure adequate airway, breathing, and circulation, including obtaining and monitoring vital signs, establishing cardiac monitoring and pulse oximetry, administering supplemental oxygen if needed, and ensuring vascular access. If time and resources permit, a 12-lead ECG should be obtained because care depends on whether the patient has adequate perfusion or is hemodynamically compromised. Assessing indicators of perfusion status, such as mental status, blood pressure, and pulses, is key. Findings that may suggest that the patient is experiencing hemodynamic compromise include changes in mental status, ischemic chest discomfort, hypotension, signs of shock, or acute heart failure. If the patient is not showing signs and symptoms of hemodynamic compromise, the patient's condition should be monitored. Cardiac monitoring, non-invasive blood pressure monitoring, and vital signs. A 12-lead ECG may be obtained, and an effort should be made to identify and address the underlying cause of the bradyarrhythmia. Consider expert consultation. If the patient has signs of hemodynamic compromise, initiate treatment immediately. It may be necessary to implement multiple treatment measures simultaneously. First-line therapy is with atropine. Second-line therapies include transcutaneous pacing and beta-adrenergic agonists. Consider expert consult and transvenous pacing if first and second-line therapies are not effective. Atropine is an anticholinergic drug that increases SA node firing by counteracting vagus nerve action to increase the heart rate. It is the first-line therapy for bradyarrhythmia with hemodynamic compromise. Administer a 1 milligram bolus intravenously every 3 to 5 minutes, up to a maximum dose of 3 mg. If the atropine is having no effect, do not wait to reach the maximum dose of atropine before initiating second-line therapies. If at any point atropine is not effective, consider initiating transcutaneous pacing as a second-line therapy. Consider implementing transcutaneous pacing immediately if vascular access is difficult to achieve. Transcutaneous pacing can be painful. If the patient's clinical condition permits, administer sedation or analgesia before pacing. After initiating pacing, verify electrical capture, evidenced by wide QRS complexes and tall, broad T waves following each pacing spike on the monitor. Confirm mechanical capture by assessing the patient for clinical signs of improved cardiac output. Epinephrine or dopamine may be administered to patients with symptomatic bradycardia as an alternative second-line therapy. These medications may also be considered when the cause of the bradyarrhythmia is an overdose with a beta blocker or calcium channel blocker. The initial dose is 2 to 10 microgram per minute by intravenous infusion for epinephrine or 5 to 20 microgram per kg per minute by intravenous infusion for dopamine, and then the dose is titrated to the patient's response.
Tachyarrhythmias are abnormal heart rhythms with a ventricular rate of 100 or more beats per minute. These rhythms are classified as either narrow or wide complex tachycardia with further subdivision into regular or irregular rhythm. Tachyarrhythmias can be categorized as narrow complex or wide complex. Narrow complex tachyarrhythmias include sinus tachycardia, atrial flutter, supraventricular tachycardia, SVT, and atrial fibrillation. These arrhythmias usually originate above the ventricles in the atria or AV node and run normally through the bundle branches, producing a normal QRS complex. Wide complex tachyarrhythmias originate in the ventricles and include monomorphic and polymorphic ventricular tachycardia, torsades de pointes, a form of polymorphic ventricular tachycardia, and ventricular fibrillation. Supraventricular tachycardia with aberrant conduction can also produce a wide complex tachyarrhythmia. Sinus tachycardia, the most common tachyarrhythmia, is identical to normal sinus rhythm, except the rate is between 100 and 150 beats per minute. Sinus tachycardia is a normal physiologic response when the body is under stress, such as that caused by exercise, illness, or pain. It may also be seen in patients with heart failure, lung disease, shock, or hyperthyroidism. Atrial flutter is caused by an ectopic focus in the atria that causes the atria to contract at a rate of 250 to 350 beats per minute. The underlying mechanism of atrial flutter is most often a reentrant circuit that encircles the tricuspid valve annulus. Supraventricular tachycardia, SVT, is an arrhythmia originating above the ventricles. In general, the rate is greater than 150 beats per minute, which helps to differentiate SVT from sinus tachycardia. SVT can be classified as AV nodal reentrant tachycardia, AV reciprocating causes tachycardia and atrial tachycardia. Atrial fibrillation is caused by multiple ectopic foci in the atria that cause the atria to contract at a rate of 350 to 600 beats per minute. Rarely, the atrial rate may be as high as 700 beats per minute. The AV node only allows some of the impulses to pass through to the ventricles, generating an irregular rhythm that is completely chaotic and unpredictable. Ventricular tachycardia occurs when a ventricular focus below the bundle of His becomes the new pacemaker. The ventricles contract rapidly, usually at a rate faster than 100 beats per minute, and usually with a regular rhythm. The rapid ventricular rate significantly diminishes cardiac output and can only be sustained for a short period before the patient becomes hemodynamically compromised. Ventricular tachycardia can quickly turn into ventricular fibrillation, leading to cardiac arrest. Torsades de Pointes is a highly unstable form of polymorphic ventricular tachycardia that may revert to sinus rhythm or degenerate into pulseless ventricular tachycardia or ventricular fibrillation. The patient's appearance on rapid assessment can vary widely depending on the arrhythmia. The patient may appear to be in minimal distress, show signs of hemodynamic compromise, for example, pale, mottled, or cyanotic skin, or show signs related to the underlying cause of the arrhythmia, for example, pain, diaphoresis. Conduct a primary assessment following the ABCD approach and provide care as needed. Obtain and monitor the patient's vital signs. Establish cardiac monitoring, pulse oximetry, and vascular access, and be prepared to provide CPR and defibrillation if the patient's condition deteriorates. Provide the minimal level of supplemental oxygen needed to maintain an oxygen saturation of at least 94% to 99% and provide assistance with ventilation if needed. Assess level of consciousness in patients who appear to have changes in mental status. Obtain a 12-lead ECG if time and resources permit. The goals of the secondary assessment are to identify signs and symptoms and determine whether they are being caused by the arrhythmia or another condition. Further determine the severity of the signs and symptoms. Identify the arrhythmia, if not done as part of the primary assessment. Identify potentially reversible causes of the arrhythmia. When tachyarrhythmia is suspected, the team takes actions to ensure adequate airway, breathing, and circulation, including obtaining and monitoring vital signs, establishing cardiac monitoring and pulse oximetry, administering supplemental oxygen if needed, and ensuring vascular access. If time and resources permit, a 12-lead ECG should be obtained. When a patient is found to have tachyarrhythmia with a pulse, take a 3-step approach to determining appropriate care. Next, if the patient's heart rate is greater than 150 beats per minute and the tachycardia is not presumed to be sinus tachycardia, determine whether the patient has adequate perfusion or is hemodynamically compromised. Finally, if the patient's heart rate is greater than 150 beats per minute, the tachycardia is not presumed to be sinus tachycardia, and the patient is not showing signs of hemodynamic compromise, determine whether the QRS complexes are narrow, less than 0.12 second, or wide, equal or more than 0.12 second. If the patient's heart rate is between 100 and 150 beats per minute, and the patient is not showing signs of hemodynamic compromise, the patient's condition should be monitored. For example, cardiac monitoring, non-invasive blood pressure. Monitoring vital signs. A 12-lead ECG may be obtained and an effort should be made to identify and address the underlying cause of the tachycardia. When a patient with tachyarrhythmia with a pulse has signs of hemodynamic compromise, synchronized cardioversion is indicated. If the patient's condition allows, administer sedation before initiating cardioversion. Follow the device manufacturer's recommendations for energy doses. Consider adenosine, 6 mg via rapid IV push followed by a rapid 10 to 20 mmol normal saline flush before synchronized cardioversion for a narrow complex regular rhythm if vascular access is readily available. Do not delay cardioversion to administer adenosine. If the patient is not showing signs of hemodynamic compromise, the QRS complex is narrow, and the rhythm is regular, attempt vagal maneuvers to break the tachyarrhythmia. Consider adenosine 6 mg via rapid IV push followed by a 10 to 20 ml normal saline flush if the rhythm is regular. An additional 12 mg dose of adenosine followed by a normal saline flush may be given if the rhythm does not convert. Consider a calcium channel blocker or B blocker if the rhythm is not regular, adenosine is ineffective, or the tachyarrhythmia recurs. Consider expert consultation. If the rhythm is wide, QRS complex more than or equal to 0.12 second, regular and monomorphic, and the patient does not have signs of hemodynamic compromise, the rhythm may be supraventricular tachycardia with aberrant conduction. In this case, consider adenosine, 6 mg via rapid IV push followed by a 10 to 20 ml normal saline flush. For a patient without signs of hemodynamic compromise and a wide rhythm, consider an antiarrhythmic medication, procainamide, amiodarone, or sotalol. Procainamide, avoid in patients with known prolonged QT intervals or congestive heart failure. Administer 20 to 50 mg per minute until the arrhythmia is suppressed, hypotension develops, the QRS duration increases by more than 50%, or a maximum dose of 17 mg per kilogram is given. The maintenance infusion is 1 to 4 mg per minute. Amiodarone, administer 150 mg over 10 minutes. Repeat as needed if the tachyarrhythmia recurs. The maintenance infusion is 1 mg per minute for the first 6 hours. Sotalol, avoid in patients with known prolonged QT intervals. Administer 100 mg, 1.5 mg per kilogram, over 5 minutes. When a patient with wide complex ventricular tachyarrhythmia with a pulse has signs of hemodynamic compromise, synchronized cardioversion is indicated. Cardiac arrest is a major global health concern. It accounts for almost 30% of the global mortality rate, with a poor survival rate of in-hospital cardiac arrest. The survival rate for out-of-hospital cardiac arrest, OHCA, is worse. Rhythms associated with cardiac arrest include ventricular fibrillation, pulseless ventricular tachycardia, pulseless electrical activity, PEA, and asystole. The first step in recognizing a cardiac arrest rhythm is establishing that the patient does not have a pulse by checking for a carotid pulse. Ventricular fibrillation is characterized by erratic, rapid, and completely ineffective depolarization of the ventricles. Rather than contracting, the ventricles quiver. This rhythm is fatal if not corrected quickly. Causes. Precipitating causes of ventricular fibrillation include myocardial ischemia or infarction, shock, electrocution, stimulant overdose, and ventricular tachycardia, including torsade de pointes. ECG findings. The rhythm is irregular and there are no discernible P waves, QRS complexes, or T waves. The waveforms that are seen may vary in amplitude from coarse to fine. As ventricular fibrillation progresses, the waveforms may change from coarse to fine and eventually disappear, asystole. Patients in ventricular tachycardia may or may not have a pulse. Pulseless ventricular tachycardia occurs when the ventricles are not contracting effectively enough to sustain sufficient cardiac output. Causes. The underlying causes of pulseless ventricular tachycardia are the same as for ventricular tachycardia and include heart disease or damage. As for myocardial infarction, certain medications and electrolyte imbalances. ECG findings. In pulseless ventricular tachycardia, the ventricular rate is usually greater than 180 BPM, and the QRS complexes are very wide. Pulseless electrical activity, PEA, is a term used to describe several rhythms that are organized on ECG. For example, the QRS complexes are similar in appearance, but the patient has no palpable pulse. The heart's conduction system is functioning, but the myocardium is not contracting, or contracting too weakly, to produce cardiac output, or volume is not sufficient to maintain cardiac output. P may be seen immediately after successful defibrillation of a patient with ventricular fibrillation, or pulseless ventricular tachycardia. But when PEA is the presenting rhythm, primary PEA, the underlying cause is usually a condition that either affects contractility or ejection, for example, hypoxia, acidosis, anterior wall myocardial infarction, or leads to inadequate preload, for example, severe hypovolemia, pulmonary embolism, tension pneumothorax, cardiac tamponade, right ventricular, infarction. ECG findings. In PIA, the monitor shows an identifiable rhythm, but no pulse can be palpated. The rhythm may be sinus, atrial, junctional, or ventricular in origin. The rate may be fast or slow. The QRS complexes are similar in appearance and may be narrow or wide. When the cause of the PEA is cardiac in origin, it is most common to see a slow rate and wide QRS complexes. Non-cardiac causes of PA are often associated with a rapid rate and narrow QRS complexes. In asystole, there is no electrical activity and therefore no contraction. Causes. Asystole is often the terminal rhythm in untreated pulseless ventricular tachycardia or ventricular fibrillation, or when resuscitation efforts are unsuccessful. Other causes include narcotic drug overdose, hypothermia, myocardial infarction, pulmonary embolism, hyperkalemia, hypoxia, drowning, suffocation, and indirect lightning strike. ECG findings. Asystole is characterized by a lack of discernible electrical activity on ECG, which results in a flatline appearance. Very rarely, the sinoatrial SA node may generate impulses that cause atrial depolarization but are completely blocked at the atrioventricular AV node, resulting in P-wave asystole. When caring for a patient in cardiac arrest, it is important to recognize reversible causes for the arrest and address them. This is especially important with PEA and asystole, which often have reversible underlying causes. The mnemonic H's and T's can help you to remember the reversible causes of cardiac arrest. While resuscitation is underway, review the patient's medical history with the providers who were caring for the patient at the time of the arrest or family members to identify details that could point to one of the H's or T's as an underlying cause. Of particular importance are changes in the patient's clinical condition leading up to the arrest, disorders or situations that could predispose a patient to developing one of the H's or T's, risk factors for cardiac and pulmonary conditions, and medication use. Diagnostic studies that may prove useful for identifying underlying causes of the cardiac arrest include a 12, lead ECG, arterial blood gases, a serum electrolyte panel, chest radiography, and bedside ultrasonography. Although some diagnostic studies can be done while resuscitation efforts are underway, others, such as a 12-lead ECG, should be delayed until after return of spontaneous circulation, RSASC, is achieved. Hypovolemia, a reduction of fluid volume in the circulatory system, develops because of excessive blood or fluid loss, for example, because of trauma, internal bleeding, or severe dehydration. A fluid challenge can aid in determining whether hypovolemia is contributing to the cardiac arrest. Suspect hypoxia in any patient who had respiratory difficulties preceding cardiac arrest. To address hypoxia as a cause of cardiac arrest, ensure that the patient's airway is patent and provide adequate ventilation and supplemental oxygen. Acidosis can impair cardiac function, in some cases to the point of cardiac arrest. Acidosis can occur in a multitude of conditions, including shock, diabetes, and acute or chronic renal failure. Arterial blood gases are used to confirm the diagnosis of acidosis. In patients with metabolic acidosis, the administration of an initial dose of sodium bicarbonate, 1 mg/kg, may be indicated. If administering sodium bicarbonate, ensure adequate ventilation for removal of carbon dioxide, or sodium bicarbonate may worsen intracellular and tissue acidosis. Potassium imbalances can precipitate cardiac arrest. Suspect hyperkalemia in patients with acute or chronic renal failure and in those who had wide QRS complexes and tall, peaked T waves on ECG prior to the arrest. Several measures may be taken to reduce potassium levels, including administering sodium bicarbonate, glucose and insulin, or nebulized albuterol. Sodium bicarbonate is the preferred method of addressing hyperkalemia in patients in cardiac arrest because it causes a rapid shift in serum potassium level. Other therapies take much longer to work. Suspect hypokalemia in patients with dehydration or overuse of diuretics. In hypokalemia, flat T waves, prominent U waves, and possibly prolonged QT. Intervals may be seen on ECG before arrest. Treatment is intravenous administration of a dilute solution of potassium chloride. For patients with severe hypothermia, body temperature less than 30 degree, and cardiac arrest, core rewarming with cardiopulmonary bypass, extracorporeal blood warming with partial bypass, or thoracic lavage with warmed fluids is indicated. Warmed fluids and warmed humidified oxygen may be administered as adjunctive therapies. Overdoses of both illicit and therapeutic drugs and poisoning can induce cardiac arrest. Drugs that are frequently implicated in cardiac arrest include cocaine, methamphetamines, opioids, heroin, fentanyl, B blockers, calcium channel blockers, digoxin, and tricyclic antidepressants. Reversal agents are specific to the toxin, for example, glucagon for beta blocker overdose, sodium bicarbonate for tricyclic antidepressant overdose, naloxone for opioid overdose. Cardiac tamponade occurs when fluid accumulates in the pericardial sac, compressing the heart and preventing it from pumping effectively. Causes of cardiac tamponade include trauma, cancer, renal failure, infections, and idiopathic pericarditis. Cardiac tamponade may also be seen postoperatively. Pre-arrest physical examination findings may include the 3 cardinal signs of cardiac tamponade, Beck's triad: hypotension, weak pulse or narrow pulse pressure, muffled heart sounds, and jugular venous distension. In a patient with PEA, narrow QRS complexes and electrical alternans, for example, beat-to-beat variation in the amplitude of the QRS complexes, may be seen. Treatment is pericardiocentesis, needle aspiration of fluid from the pericardial sac. Tension pneumothorax occurs when air accumulates in the pleural space, causing the lung on the affected side to collapse and the mediastinum to shift, compressing the heart and vena cava. Compression of the vena cava leads to impaired venous return and decreased cardiac output. Penetrating chest trauma is a common cause of tension pneumothorax, but the condition can also develop in older patients with underlying lung disease and in patients who smoke. Pre-arrest physical examination findings may include hypotension, tachycardia, absent breath sounds on the affected side, jugular venous distension, hyperresonance on percussion, and tracheal deviation away from the affected side, a late sign. Difficulty ventilating the patient may also be a sign of tension pneumothorax. In a patient with PEA, narrow QRS complexes should raise suspicion for tension pneumothorax as a possible underlying cause. Initial treatment is with needle chest decompression or thoracostomy. In massive pulmonary embolism, obstruction of the pulmonary artery, and the release of vasoconstrictive mediators from the thrombus lead to cardiogenic shock, which can quickly lead to cardiac arrest. Conditions: in the patient history associated with prolonged immobilization or venous stasis, hypercoagulability or damage to the veins should increase suspicion for pulmonary embolism as a potential cause of cardiac arrest. Witnessed cardiac arrest and respiratory distress before arrest also may point to pulmonary embolism as the cause. PEA is the initial rhythm in 1/3 to 1/2 of patients with cardiac arrest caused by pulmonary embolism. Fibrinolytic therapy may be initiated for patients with known or suspected pulmonary embolism. Myocardial infarction can lead to cardiac arrest. If a pre-arrest 15-lead ECG shows an inferior wall myocardial infarction with right ventricular involvement, evidenced by ST segment elevation in lead V4R, then impaired preload is likely the cause of cardiac arrest, and fluid bolus therapy should be provided during resuscitation. If a pre-arrest 12-lead ECG shows anterior wall myocardial infarction, then impaired contractility is the likely cause of cardiac arrest. When myocardial infarction is the suspected cause of cardiac arrest, a 12-lead ECG should be obtained after ROSC is achieved to guide therapy, and inotropic support may be needed to address cardiogenic shock. After determining that the patient is not responsive, not breathing, and has no pulse, call for additional resources, the rapid response or resuscitation team, and the resuscitation equipment or CART, and initiate CPR immediately. Without interrupting high-quality CPR, attach the cardiac monitor defibrillator and identify the arrest rhythm. When a patient is in cardiac arrest, treatment focuses on providing high-quality CPR, providing shocks if the rhythm is shockable, or early epinephrine if the rhythm is non-shockable, and, if possible, determining and addressing the underlying cause. For non-shockable rhythms, epinephrine should be administered as early as possible. For shockable rhythms, medication administration should be delayed until after at least 2 shocks have been given. Placement of an advanced airway and establishment of capnography should be delayed until after at least 2 shocks have been administered in the case of a shockable rhythm, or CPR has been provided for at least 2 minutes in the case of a non-shockable rhythm. Ventricular fibrillation and pulseless ventricular tachycardia require defibrillation as soon as possible. Because shocks may not be successful, or, in the case of successful defibrillation, the resultant rhythm may not be adequate to sustain perfusion or a pulse, resume CPR immediately after each shock. After every 2 minutes of CPR, reassess the rhythm while minimizing interruptions to chest compressions to determine next actions. If the rhythm is shockable, resume CPR immediately and administer 1 shock as soon as the defibrillator is charged. If the rhythm is non-shockable and organized, attempt to palpate a pulse. If a definitive pulse is palpated, the patient has return of spontaneous circulation and post-cardiac arrest care should be initiated. If a definitive pulse cannot be palpated, resume CPR immediately and follow the code card pathway for a non-shockable rhythm. Repeat cycles of 2 minutes of CPR, rhythm check, shock, and medication as appropriate until the rhythm check reveals a non-shockable rhythm, return of spontaneous circulation is achieved, or the resuscitation effort is terminated. Clinical indications of ROSC include a palpable central pulse and measurable blood pressure, a sudden and sustained increase in ETCO2, or an arterial pulse waveform on an arterial line when no compressions are being delivered. Additional signs, such as patient movement, normal breathing, or coughing, may be present. The energy dose depends on whether the defibrillator is biphasic or monophasic. Providers should familiarize themselves with the equipment used in their facility. Various medications may be used in the treatment of ventricular fibrillation or pulseless ventricular tachycardia. Remember that in cardiac arrest, all medications administered through the IV or IO route should be followed by a 10 to 20 ml normal saline flush. After 2 shocks have been delivered, epinephrine, 1 mg IV-IO every 3 to 5 minutes, may be administered. After 3 shocks have been delivered, consider administering an antiarrhythmic agent. The initial dose of amiodarone is 300 mg administered as an IV-IO bolus. If the arrest rhythm persists, consider giving a second dose of 150 mg after the 5th shock. Defibrillation is not indicated when the rhythm is PA or asystole. Management of these rhythms involves providing continuous high-quality CPR, administering epinephrine, 1 mg IV-IO repeated every 3 to 5 minutes, as early as possible, and performing rhythm checks after every 2 minutes of CPR. In addition, it is extremely important to look for and address potential underlying causes of the cardiac arrest. P and asystole often have an underlying cause, and unless that cause is addressed, the resuscitative effort will not be successful. Repeat cycles of 2 minutes of CPR, rhythm check, and medication as appropriate until the rhythm check reveals a shockable rhythm, ROSC is achieved, or the resuscitation effort is terminated. Post-cardiac arrest care includes interventions aimed at optimizing oxygenation, ventilation, and perfusion, minimizing the systemic consequences of cardiac arrest, preventing future cardiac arrest, and assessing the patient's prognosis for recovery. If not already done, place an endotracheal tube. If an endotracheal tube is already in place, confirm proper position and patency. Start ventilations at a rate of 10 breaths per minute and adjust as necessary to keep carbon dioxide levels in physiologic range between 35 and 45 mHg. Maintain an oxygen saturation, SaO2, of 94% to 99%. Target a minimum systolic blood pressure of 90 mHg or a mean arterial pressure, MAP, of 65 mHg. Initially treat hypotension with a 1 to 2L intravenous IV isotonic crystalloid fluid bolus. If the patient fails to respond to fluid, consider starting an IV vasopressor infusion. Obtain a 12-lead ECG expediently. As time and resources permit, obtain a medical history and complete focused physical and neurologic examinations. Maintain euglycemia and identify treatable underlying causes, including H's and T's. Diagnostic studies aid in determining the pathophysiologic consequences. Targeted temperature management protocols should be considered for all patients who remain comatose after ROSC, as indicated by an inability to follow verbal commands. A target temperature between 32 degrees and 37.5 degrees is established. The patient's body temperature is maintained at the targeted temperature for at least 24 hours.